first of all, I would like to make a land acknowledgement. I live in Montreal. I work in Montreal, so all my work is in Teotihuacan, Montreal, which takes place on the unceded indigenous lands of the Kanien'kehá:ka Mohawk Nation. And Kanien'kehá:ka is known as a gathering place for many First Nations, and I recognize the Kanien'kehá:ka as custodians of the lands and waters on which I live and I work. So here is an outline of my presentation. So here are some pictures recalling us the first lockdown last spring. So, the streets which are empty, the number of cases, protective equipment, everything was closed, testing, which was, we had scarce resources for testing at the beginning. So just a remembrance. So as you know, during the first wave, the COVID-19 pandemics led to temporary closure of disease and living donor transplantation programs. In Europe, a third of transplant programs perform transplantation only in urgent cases or with sickest patients. 4 out of 23 UK kidney transplant program closed. In Quebec, all our kidney transplant program closed from end of March to June, beginning of June 2020. Well, we, however, continue to proceed to transplant for highly sensitized patients. In the US, during the first wave, there was a near cessation of living donor kidney transplantation. There was also a decreased number of deceased donor transplantation among all organs. And as you can see, the most important decrease was in lung, probably because people were very cautious because these patients could get COVID and could have very bad outcomes. There was also a decrease of deceased donor recovered, a decrease in waitlist registration, and also an increase in kidney transplant waitlist deaths. And some of these deaths could be linked to COVID because, as some of you may know, there were outbreaks of COVID in some dialysis units. And there was also a decrease of disease procurement rates. That being said, in the UK during the first wave, 74% of family approached for organ donation were still interested for donation despite they were not allowed to see their loved ones. Among organ transplant recipients, there is a high mortality reported. As you can see, for kidney transplant recipients, it is between 10 and 50%. And among cellular organ recipients, including kidney, it varies between 3 and 50% of patients infected. So one of the first issue that we have to look, and we were considering at the beginning of the COVID pandemics, were risk benefits balance. So we were considering the risk of COVID-19 transmission. At the beginning, we didn't know if we could transmit it to our patient while using organs of unknown, a donor who could have COVID, versus risk of waitlist mortality. So there's still a theoretical risk, but recently there was a paper published reporting successful transplantation of organs from a deceased donor with early COVID infection. But also there was a case of a liver transplant recipient infected infected liver transplant donors. So it's still theoretical, but there's a risk. And I think it's explained why all transplant program err from the side of caution. And we rapidly, when we restart our program, we wanted the donor and also the recipient to be tested for COVID. One of the issues was also the safety of transplant professionals. Well, remember 1 year ago, there was a shortage of protective equipment for professionals. So we had to decide who would be prioritized for the safety equipment. So it could explain why people were working in hot zones, were prioritized and for protective equipment. Also, as you know, transplant teams sometimes have to travel to recover organs, and it's a because they are going other hospital, they're traveling by plane, etc. They are a higher risk of getting infection, and of course, if there's COVID-19 transmission to healthcare professional or transplant professionals, they need to self isolate and there could bring a shortage of transplant professionals. Resource allocation. This is a not new issue because it's in the world of organ donation and transplantation. Well, every day we ask ourselves, how could we best distribute the organs? Also, to perform transplantation also involve not performing or prioritizing other medical procedures. So this is not a new issue, but it was highlighted with the COVID pandemic. So a lack of sufficient resource in the larger healthcare system may be a reason to temporarily suspending transplantation programs. Indeed, in certain exceptional circumstances, it may be reasonable to place a higher priority on allocating resources for treating patients infected with COVID-19 rather than for transplant procedure and post-op care of newly transplant patients. For example, during the pandemic, the need for ICU resources has substantially increased with an impact on capacity to care for transplant patients who might also require these resources. On the other hand, we should also consider that in some situations, uh, as for lung transplant candidates or liver or heart transplant candidates, transplanting these patients who are already in ICU may actually free up ICU resources, as the transplant could allow for recovery and transfer out of the ICU. Another issue related to resource allocation during the COVID-19 pandemics is whether it is morally acceptable to pursue deceased organ donation in a time of ICU resource scarcity. Maintaining a deceased donor requires mechanical ventilation, ICU beds, and human resource. One could argue that these donors are competing with COVID-19 patients for ICU resource. On the other hand, taking care of the deceased donor will benefit and potentially save the life of multiple other transplant recipients. Another important issue to consider is informed consent. It's not, of course, it's not a new ethical issue, but since it's more complex in that setting of uncertainties. So, and also it's the informed consent could be informed from could be obtained in a virtual form, which is new. So we have to think about how to get the informed consent from donor, transplant recipient. And a recent survey with kidney transplant candidates in the UK show what they wanted to know. So they wanted to know the risk of COVID-19 transmission from the donor and during the hospital stay, how COVID-19 has affected kidney transplant recipient and immunosuppressed patient, what are the precautions put in place to reduce risk of COVID-19 transmission, and precautions that patients need to take during the hospital stay and after the discharge? 1 year ago, we didn't have so much information to tell our patients. Right now, we know more about COVID, so we can inform them well, but not well, but better. But we have to. It's still there's still uncertainty, and we have to take it into account in the way we get informed consent. When we resume our transplant program, many of us decided to select the first patient that will accept to transplant. So there's a risk of cherry picking, or I don't know if Matt Weiss is there, or pepper picking, as you prefer. So we could be tempted to select transplant candidate who will not need long hospital stay and will not need rehab. So it will advantage younger patients with less comorbidities, because we know older patients will stay longer, we need rehab. We could also avoid patients who will need T cell depleting therapy, because it could theoretically decrease the recipient immune response to a COVID infection. So again, it could disadvantage some patient. And we could also be thinking of skipping someone on the list because he or she lives with someone at high risk of being infected. So we could think about someone living with essential worker who are at high risk of being infected, or living with people who refuse vaccine. And again, we could disadvantage already disadvantaged populations. And we have seen that the COVID had highlight all the disparities that we have in our societies. And just in Montreal, some neighborhoods of where immigrants lives were particularly affected by COVID. So again, we have to take into account that we could disadvantage already disadvantaged patients. So here, I think it's an interesting study. It was a survey done with patients in the UK. And what do patients want when we resume our deceased donor kidney transplantations? So it's interesting to see that the majority of patients wanted to be reactivated as soon as the transplant program reopened, and 68% were ready to give consent for kidney transplantation, right now. The majority of patients had no concern, trust the nephrology team, and many patients describe an urgency to be transplanted. They had, however, some concerns. So, again, risk of COVID 19 transmission from the donor and during the hospital stay, the psychological impact of receiving a kidney transplantation in a context of high psychological stress, exposing other members of their household to the risk of being infected, lack of social support because of self-isolation and social distancing, and impact of COVID-19 on chances to be transplanted, fearing not being reactivated. Here is another study with, again, kidney transplant program. So some people could say that I'm kidney biased, of course, because I'm a transplant nephrologist, but there's no other studies with other organs. So it is a qualitative study performed in the Australia with kidney transplant patient caregivers and living donors. And here are the major themes that they found. So cascading disappointment and devastations. Well, shattering hope. Patients are traumatized when the transplant program stalled because it was their hope. Frustration of starting the workup again if it's too long between two workup, succumbing to defeat because they felt powerless, feeling in a limbo for waiting for a decision for their transplant. Guilt for potential living donors, feel guilty that the living donor kidney transplantation was canceled. There was also helplessness and vulnerability. So fear of declining health, for fear of not being alive for the transplant, dying when the transplant program stopped, confronted by dialysis, feeling disconnected from healthcare, and also the higher susceptibility to infective complication. Also, the stress for uncertainty, so confusion from conflicting information, unable to forward plan. So being on standby is particularly difficult for a living donor, and also exacerbating burdens, so incurring extra financial costs, intensifying caregiver responsibility, and also, there was a theme of sustaining health through the delay. So, protecting eligibility, donors told that they need to remain healthy, particularly those who were participating in KPD, and relying on social support to cope from extra waiting time, and adapting also to emerging modalities of care such as telehealth and self-monitoring. So the conclusion of these authors is the importance of a well-designed communication strategy for suspension of transplantation programs with periodic updates, access for patients to counseling to manage stress, uncertainty, and anxiety. So I just want to give a small example. In January, our Minister of Health in a press conference told to the population that all kidney transplantation programs were altered. And it was not true because we still continue, but with some limitation. But our patients, which, you know, hear, hear that at the TV, were completely stressed, but it was not so. It's really important to have a clear communication strategy. What living organ donor wants, what were their care priority during the COVID-19 pandemic. This is a survey conducted in the US with past donors and potential donors. So their perceptions of COVID-19 related risk were concerned about kidney damage by COVID-19 because they have only one kidney left. They were worrying about risk of COVID-19 transmission. They mentioned an increased need to be hyper vigilant about health after donation, mental health and stress, availability of medical care, and difficulty of making decisions given the quantity of information and misinformation. And the decision to donate depends on recipient medical needs and availability of tests. I just want also to discuss vaccination and transplantation. Should we oblige our patient to get the COVID-19 vaccine to be put on the wait list? Because we know probably the immune response would be probably better before they are immunosuppressed. So this is an ethical analysis that recently published in AGT by Cates and colleague. And I think they were just looking about vaccination in general, and they were looking in the pediatric context. And apparently in the US, if a patient refuse a vaccine, only half of the pediatric program would list the patient, 22 would not, and 30% were unsure. And I think, well, there are benefits of making it obligatory for a patient, to decrease the risk of COVID-19, but we have also to balance it with an issue of respect for autonomy and also justice, because we know some category of patients have mistrust in the system, such as indigenous people. And again, another recent paper looking about living organ donors and vaccinations, because living organ donors, well, in Quebec, were not prioritized for vaccination. So it was an online survey of living donor in the US, and 62% plan to receive the vaccine, 15 have already received, 11% do not plan, and 12% were unsure. And reason for planning to have the vaccine were benefits of COVID-19 vaccine outweighed concern about safety of COVID-19 vaccine, a desire to protect organ recipient from COVID-19, and motivation to avoid COVID-19 infection among the donors due to concern about the potential impact on their remaining kidney. And the reasons for not planning or answer to receive the vaccines were concern about vaccine safety, perspective that COVID-19 is not a serious threat, and that also the belief that previous infection with COVID-19 is more protective than vaccination. So, in conclusion, COVID-19 has highlighted disparities in access to care, and we shift from an ethical framework based on respect of autonomy to justice, safety, accountability, and beneficence. And I think it also highlights how it is important to have transparent and clear communication of risk in time of uncertainty. So, thank you, and I will be glad at the end of the panel to answer your questions.
Merci beaucoup, Marie-Chantal. Thank you so much. It's very interesting to see how the impacts that COVID had on organ transplantation, especially on the content of informed consent, on such a usually such a difficult issue, so exacerbated here by COVID. And I see a parallel, of course, with the vaccination with the AstraZeneca um, flu shots, and very interesting also to see the impact on inequity in the context of the selection of the patients. So if you have a question for Marie-Chantal, please write them down in the Q&R, and it will be my pleasure to redirect the question to her at the end of the presentation. So without further ado, let me introduce Simon Oczkowski. He's an intensivist professor at the Faculty of Health Sciences at McMaster University. And welcome, Simon. And the title of the presentation today is "If You Choose Not to Decide, You Still Have Made a Choice: Pandemic Resources Allocation and ODT." You can start now, and you have 15 minutes. Thank you.
Go. So for some reason, I wasn't able to start my video there. I don't know if...
Sorry about that. I just sent you a request, yeah.
Wonderful. Thanks very much. So Jennifer asked me to do this presentation back in January of 2020. And she said, can you talk a little bit about resource allocation during the pandemic and impacts upon organ donation and transplant? And that was right before we entered the second wave, followed by wave 2.5 or wave 3, whatever you want to call it, that we're just coming out of now. And so, this is a topic that is in evolution, and I'm going to be speaking to it from the perspective of an intensive care physician and sort of try and explain how we've been allocating resources during the pandemic. I've been working on our critical care triage policy at our institution here in Ontario, and that's been the framework used in other areas around the country. But I am going to take a sort of Ontario-centric approach, and I apologize for that because everyone from Ontario does that. But what I'm going to talk about today is the impact of COVID-19 on critical care capacity. This has been talked about in the media a lot, but I'm going to show you some graphs and sort of demonstrate how exactly we allocated our critical care resources during the most recent pandemic surges. And then I will talk about some of the potential impacts upon organ donation and transplant activity, recognizing we haven't actually fully felt these impacts. And Marie-Chantal's already demonstrated for us that these are numerous and far-reaching, and so I'm going to sort of keep this within the ICU hospital ODT sphere. So COVID-19 put a tremendous strain on our intensive care units during this most recent wave 3 in Ontario, in Alberta. Manitoba is only now starting to come to grips with it, but almost every province in Canada has really struggled with this most recent strain. This is data from howsmyflattening.ca, a website that has been collecting and collating data related to COVID-19 for the public to see. And what you can see here is this is in Ontario, we normally have around 1,100 ICU beds available, level 3 beds that can manage ventilators. So this is critically ill patients, either potential neurologically deceased donors or patients who are critically ill after organ transplantation. And you can see that sort of in July and August, the vast majority of patients in the ICU were non-COVID patients. The yellow group at the bottom, you can see that first bump there, that's wave 2, and then wave 3. And as we moved into wave 3, we actually got beyond our hospital capacity for ICU across Ontario. And you can see there that line of 1400, the crisis zone, is when we would start having to allocate resources and initiate critical care triage. That's sort of the area where people think it would be, is around that 1400 mark. So how did we adapt to this, and what are the potential implications on ODT activity? So the Ontario triage framework basically had a three-step process for responding to a pandemic surge. So the first aspect was building surge capacity in our ICUs. This is a photo of one of our ICU rooms. I took this because I couldn't believe we actually had empty beds again. It was such a thrill to actually see we had resources available. And I took this photo, but this is normally a two-person room. It is a three-person room. In my hospital, every single room we had to adapt and modify in order to add extra patients. And our hospital, which normally has around 25 beds, had up to 40 patients in it. This requires massive influx of resources, redeploying resources from across the hospital. So taking OR room and ER staff and redeploying them to our intensive care unit, using transport ventilators that are normally used to move patients between areas of the hospital or between sites. We also had to defer all what was called non-essential care, and this was mandated by the provincial government, what operations could and could not be done. And this was done in terms of prioritization, in terms of what could be deferred. So cancer surgeries, for instance, would be a higher priority than elective knee or hip. And then the other thing is we developed regional and a more system-based approach towards managing. So normally, we'll often have in Ontario hospitals that are very full in some areas and empty in others. We used an IMS command system transporting over 20 patients per day at the height of the pandemic between various regions. Second step in responding is adjusting the standard of care. So accepting less than the best you could have provided at the normal times. This is a photo of our intensive care unit. You see all of the equipment there in the hallways, very limited space. Staff are going into the room less than usual, so we're doing interventions and assessment less often to reduce the use of PPE. So we're standardizing and streamlining our care, modifying our patient to staff ratio to whatever is available, and using unconventional equipment and medications as things become scarce. And so we're actually able to increase our capacity markedly through these mechanisms and manage to make our human resources stretch even farther. The third step, which we very fortunately never had to move towards, was what we call critical care triage. And this is basically a formal acknowledgement that the demand for critical care beds has been exceeded and that patients are going to die who otherwise would have potentially lived if they had received some resources. The goal here was to create an accountable, transparent, fair, rational process for allocating these beds. And we worked on this from wave 1 all the way through wave 3, multiple iterations. And the reason we engage in this process is it's recognized that if you do not engage in a formal triage process, as much as it has an ick factor to the idea of withholding resources from a patient you would normally provide them to, if you do not do it formally, informal triage will occur at the bedside because there's simply not enough resources. And so the Ontario approach we took was using what was called the short-term mortality risk, or STMR, where we looked at a patient's mortality risk at 1 year, used the most evidence-based scales and standards that we could, and at the time of a patient requiring critical care, said, what is the likelihood of this patient surviving 1 year from the time of ICU admission? And based upon that, we would prioritize patients over 80% chance of survival, 50 to 80, less than 50, or less than 30. So we sort of divided patients up into bands of survival and would have allocated resources in accordance with that. And very fortunately, we did not get to that point even during wave 3. However, we got to a level where all of the hospitals were actually conducting simulations and exercises, looking at our patient lists and saying, if we were to implement this, what would it potentially look like? So it was, a very scary time for those of us on the front line, this idea that we might have to withhold treatments from patients who would otherwise be applying them to. And what were the principles that we looked at when creating these policies? So the principles for triaging patients during the surge were Pretty straightforward in what we would imagine. I mean, the first thing that came to mind was saving the greatest number of lives possible, and this was the rationale for using the short-term mortality risk indexes. You know, utility. If we have limited resources, make the most use of them we can. The second thing we looked at was non-discrimination. So within the context of applying resources to patients most likely to survive, we shouldn't be allocating resources upon prohibited grounds, you know, based upon the human rights code. So things like age, you know, sexual orientation, gender, disability, race, these are sort of prohibited grounds. And the use of a structured, standardized process is going to be more fair because similar patients should be treated similarly. At the same time, we strove to maintain proportionality. So the idea that as surge got worse, we would exclude patients with a lower chance of survival. So at the very beginning, you know, we would be letting patients in the unit who had a reasonable chance of surviving. By the time we start to completely run out of resources and we're in the highest stages of triage, only the patients with the greatest chance of survival would ever get in. And the idea is you have this proportional response to the crunch in resources. We would aim for equity, so we want to incorporate procedures and measures to minimize exacerbating the effects of discrimination and marginalization. So we would try to have multiple clinicians evaluating patients. We would have oversight done at a regional level and created a regional triage oversight body. And then accountability. So the idea is that doing this in a transparent manner also holds individuals accountable for your actions. So we heard lots of stories, and whether or not they're true, it's not totally clear to me, from other regions around the world where clinicians were having to make triage decisions, and you know, those decisions were just kind of left in the void. You know, there's no beds here, please go to a different hospital, and people would be turned away. Where is the accountability for these sorts of decisions, and who should they, who should the responsibility for this lie upon? And so that's why we wanted to have a well-documented and accountable process, and the principle of autonomy. You know, to the greatest extent possible, allowing people a choice. So our first step in any triage process is assessing what kind of resources someone would want applied to them. If a patient does not want to go to ICU, that patient should not be triaged for an ICU bed. And so trying to facilitate to the greatest extent possible choice for individuals under these sorts of circumstances. And at the end of the day, the impact upon organ donation and transplant comes down to, if we're going to look at utilitarianism as being the primary principle we're looking at in triage here, is resources to save lives of pandemic patients versus the resources to save lives by organ donation and transplantation, and how do we balance these? And the impact upon organ donation and transplant are numerous, and I don't think we totally have an exhaustive list here by any means, but you know, the infection control procedures, so lack of PPE, isolation, cohorting of patients, makes it really difficult to care for immunocompromised patients in hospital. Immunocompromised post-transplant patients are often going to avoid seeking care. My wife's a rheumatologist and cares for many immunocompromised patients, including some post-transplant, and they were avoiding hospitals, and this was for sure impacting the care of individuals who had received transplants. The staffing issues related, so there's diminished ICU staffing as you adjust models of care. There's incredible amounts of change fatigue as clinicians are struggling to adapt to changes in policy around visitation, care models every single day over the course of a year. This results in burnout. We also had diminished OR staffing, as many of our OR staff were actually redeployed to the ICU. So even if you had a potential donor, you're going to have difficulty getting the staff in for the OR. The adjusted standard of care in the ICU might not be sufficient for optimal organ donation donor management, and may not be sufficient for managing post-transplant patients whose needs are very complicated. And then lastly, and most obviously, is, you know, the loss of ICU capacity. And this impacts absolutely every aspect of organ donation and transplant, because, you know, the triage process, if enabled, would actually exclude patients at the highest risk of dying. And these are the deceased donors who would be potentially providing many of the transplantable organs. At the same time, reduction of ICU capacity is going to result in a reduction in scheduled care. As Marie-Chantal pointed out, many organ transplantation programs, living donor programs were either suspended or had reduced activity during the waves of COVID. And this was because we had a scarcity of post-operative ICU beds. Where do you put these patients afterwards? Do you cohort them with COVID patients who are everywhere in the hospital? Do you put them in, unconventional spaces? It was a real struggle to try and figure out where to put patients, as we were actually shuffling them all around the province, all through various areas of our hospital, trying to make enough room to get everyone through it. So there's many mechanisms by which organ donation, transplantation activities were impacted during the pandemic. These are just a few of them, but there are many, many other downstream effects that are not listed here. So how do we adapt organ donation and transplant to a pandemic? So Trillium Gift of Life in Ontario recognized the need to preserve ICU resources, and most of the efforts were focused on building capacity and adjusting standards of care. And Trillium made a really, really concerted effort to increase the efficiency of operations, recognizing that every day a deceased donor is taking an ICU bed. That's an ICU bed that's not available to take care of another pandemic patient or another critically ill patient who needs that bed. So there was expedited case management between the Trillium Gift of Life managers, organ support MDs to help facilitate decision-making, and organ and tissue donation coordinators as well, providing support to the frontline clinicians, recognizing that they're simply going to be overwhelmed with the amount of clinical care they're providing, and they really need someone to assist at the front lines there with the care they're providing to deceased donors. At concerted efforts to expedite donation workup and testing, which is often a struggle even at the best of times. And importantly, reducing the transplant program's decision window to about 2 hours before moving on to the next program. So this is a struggle on the part of the transplant programs, but really figuring out which organs are going to be going where helps you to coordinate your organ donor management and your operating room and planning all of these sorts of things. So the idea was to minimize the amount of resources taken up by Trillium Gift of Life activities. The other thing, there was concerted outreach to ICU leadership at most of the hospitals to recognize that organ donation transplant efforts were continuing. So for many clinicians fixated on the pandemic, they might actually forget the fact that donation and transplant is ongoing. Triage was not involved in any way. We didn't get to that point. So what was the impact? So this is data from CBS, and I've got a QR code here if you want to take a photo. But what you can see here is that the number of living donors and deceased donors in 2021 is definitely lower than in previous years due to a combination of these activities. Both DCD and NDD cases have been reduced, and whether or not this is due to patient-related factors, patient activity varying, or clinicians not taking the time or effort or having the time or resources to take care of these patients is unknown. So I'm just going to summarize here, the pandemic put tremendous strain upon our resources. The way we allocated resources was by building capacity, adjusting the standard of care, and triage. When demand outstrips resources, triaging of resources is going to be done, even if done so implicitly. And transparent allocation of scarce resources is really necessary to ensure principled decision about how we're doing this, so that informal triage does not take place and we use resources most equitably and in the most utilitarian manner possible. And we still do not know the full impact of organ donation and transplant. So this is going to be evolving over the next few months and years. So I'll just stop there.
Thank you very much, Simon. I think your presentation shows that the extraordinary work that I've been doing on the field from the part of the ODT specialists in transforming in a day-to-day situation in real time, the way ODT is performed. So again, if you have some questions for Marie-Chantal and Simon, please fill the Q&R, and I will be happy to direct the questions to them at the end of the the presentation. So we can now move to the next presentation from Sean Delaney. Welcome, Sean. Sean is a patient partner, Associated Director, Organ Listing and Allocation at the Canadian Blood Services. And the title of his presentation today is Running the Gauntlet, a Patient Journey Through Dialysis and Transplant in the Era of COVID. You have 15 minutes. Thank you.
Thank you so much, Michelle. Can you hear me and see my slides?
Yes, it's perfect.
Okay, fantastic. Thank you so much. I just want to congratulate Jennifer and all the organizers of this conference. This has been so well run and very enjoyable. I also want to thank or blame my coworker and transplant partner in crime, Everett, who many of you heard yesterday speaking, because he reached out to me to make this speaking opportunity a possibility. So I will try to be a bit of a break from journal articles and graphs, but no promises. There might be a graph or two still in here. So right off the bat, just a little bit about where I come from. I always love to start presentations when I'm doing a patient presentation with an old picture of myself. Number one, I just like to, it makes me laugh. And I do like reminders that I had hair. But more than that, it's also a reminder that even though we always talk about the issue of the day, the COVID, as we're talking about today, for many of us as patients, our journey, is lifelong from the moment that we're diagnosed with a condition. So in my case, I've been doing this for 49 years, and I've now outlived 2 generations of urologists. I'm about to see myself into my 3rd generation of transplant nephrologist. And so while we're all navigating the issue of the day, remember, we all have to, live with these conditions for forever. So a little bit about my health and professional background. As I said, I've been navigating renal failure or renal challenges all the way back to 1 month old. I did have full left and partial right nephrectomy due to a urinary blockage as a 1 month old infant. I lived with ureterostomy until 1980. I finally did need a kidney transplant, and my little brother was a donor for me in 1998. So that piece of my right kidney did an amazing job of getting me that far. The transplant lasted for 21 years. And so starting in 2017-18, I was seeing fairly significant renal failure on my graft, leading eventually to relisting for transplant, as well as peritoneal and hemodialysis. Professionally, I know quite a few of you on the call know a bit about me, but I have a background in public health. I have a master's in public health, specializing in health policy. I've worked in the hospital system. I worked in the government of Alberta in the Ministry of Health. I was then recruited to the Canadian Council for Donation and Transplantation in 2006, which eventually was absorbed into Canadian Blood Services in 2009. I was part of the KPD, at that time LDPE, Living Donor Paired Exchange program in its inception. We took those learnings and implemented the HSP, the Highly Sensitized Kidney Program. I oversee, or my team oversees the National HLA Advisory Committee, so the tissue typing labs. And we're currently working on some amazing new programs in heart, liver, and pediatric kidney sharing. So lots to look forward to from a professional standpoint as well. So right off the bat, I promised very few graphs, but this will be the main one. Before I talk about where my ride went during COVID-19, let's just talk about our shared humanity, what we all went through. As you can see, here's the 3 waves overlaid with the deaths in red and the first vaccines in yellow. And you can see the direct correlation there of wave 3 coming down in Canada as the vaccinations rose. And we hope that both those trajectories continue to rise. That was data as of June 3rd. So in the last 2 weeks, we've seen even more. As I said, we've seen 3 waves. These are the dates for Alberta when we went into lockdown. as you know, Alberta in the wave 2 and wave 3 was probably a little past where they should have been implementing those lockdowns, and we paid dearly for it. The last part of our shared humanity was we saw an amazing 4 different vaccine candidates approved, the mRNA and the traditional vaccines at different dates throughout this last 2 waves. And we're all now waiting to see where we're going to be going with second shots and everything else after that. So those 3 waves I'll overlay against my own journey over the last 18 months. So I began by beginning a search for a living donor, starting in October 2018. I did do back to some of the topics from yesterday about public appeals. I very heavily used my own social media. I did have a lot of conversations with family and friends, coworkers, anybody that would listen to me, just really more to tell my story, and anyone who was inspired to ask more questions. You know, I was more than open to answer any questions, put them in touch with my local living donor coordinators here in Edmonton, and just take it from there. And quite honestly, it was, you know, I started tracking it and I thought, you know, this is pretty amazing. I've got lots of people that know me. I've got lots of people that, you know, love me. This is going to be a slam dunk. And I actually didn't even think about it for the first little while, but you know, as the numbers started increasing, I you know, started my own spreadsheet to just keep track because there were so many names and numbers and dates, and then people started getting declined, or they had to defer for health reasons or things like that. And so over the course of that 2-year period from October 2018 to October 2020, I actually saw 32 individuals. This is friends, this is family, this is coworkers. It's actually a couple of you on this call. I'm not outing anybody who took that amazing step of reaching out to me and saying, yeah, I'll make that first phone call. And so 32 people I tracked all the way from the start to finish. So, I mean, in the midst of all that, there was obviously a lot of mixed emotions, ups and downs. I think I went through 5 or 6 different cross-match exercises, you know, the blood work and the call-in and things like that. But at the same time, there was also walking people through the challenges of finding out that they had a health condition they didn't know about, or they were turned down because of you know, an antibody issue or something like that. Nothing to do with themselves, just an antibody issue. And unfortunately, it was for a variety of reasons. Very few of them went any further and even looked into paired donation, which I think was kind of an interesting thing to walk to, and a challenge for me, having been on the team that implemented paired exchange in the first place. So just at the very start of and just prior to COVID, you know, coming onto the national scene, I did start onto peritoneal dialysis in August 2019. So we're now a couple months away from hearing anything about Wuhan. Many of us had never even heard of Wuhan before. But you know, once I'd seen my glomerular filtration rate fall from 15 to 10 and then to 5 and ultimately down to 4, I was feeling pretty crappy. And so I needed the surgery to implant the peritoneal dialysis catheter, went through the training, and was sent home with a bucket or the little briefcase on the right-hand side, a warming tray, and then that truck showed up with all those boxes. And I chose peritoneal because it was going to be the most portable. Remember, there's no COVID yet, so I thought this is going to be the one that allows me to, you know, stay working full time, to even travel. And can everyone remember back when we traveled for work? Yeah, so that was the reason for my choice. And in spite of that, anyone who knows me knows I'm a little bit of a glutton for punishment, but I will find a way through. So even after peritoneal dialysis, as you can see, I was playing with my grandson. We set up empty dialysis supply boxes and made them a track. Many of you saw me speak at the CST in Banff 2 years ago. I was only 3 months on dialysis, 2.5 months on dialysis at that time. And the third picture, believe it or not, was March of 2020. And who knew that all flights were about to be grounded? I was on my way to Montreal to meet with some of the folks from McGill and Genome Canada. And who knew that was the last flight that I would be on for at least the next couple of years. And then the bar on the bottom moves a little bit, and December and into January, we start hearing about this severe acute respiratory syndrome, coronavirus 2, SARS-CoV-2, and in many respects, I think we've all lived through the West Nile viruses and the H1N1s and the SARS, and how different could this be really? So I don't think it really settled in for a month or two, just how much this was going to impact us. And so, as we all know, travel came to a screeching halt. My peritoneal dialysis came to an end because my PD catheter became non-functional. So I had to kind of do a crash start onto hemodialysis. So apologies for the gory picture. That's just me getting my CVC line in. But all of a sudden, masks and hand sanitizers, no visitors coming into the hemodialysis ward with me. That was quite a sobering experience overall. And during this whole time, I'd never been on hemo before. I have spent 48 years, I guess, at that time, avoiding hemodialysis, it being the big boogeyman that I never ever wanted to see as a renal patient. And here I was in a dialysis unit for the very first time in my life. I was at this time also getting another peritoneal dialysis catheter put in because I wanted to get back to it, because I thought travel was going to restart and we'd be able to, get back to some kind of normal after this first wave was over, right? I got back onto PD shortly after that. And so for the next few months, the spring and summer of 2020, you do what you can. And as I said, I'm a glutton for punishment. So I started camping. PD, like I said, I chose it specifically because it was portable. And if you can see my little trailer there, I'm out just north of Calgary in the Ghost River Wilderness area. And where there's a will, there's a way. That's my PD pump system right inside my little trailer, and I could run it off of a generator. And so I continued to go, and that was my road trip for summer of last year. I went all the way into southern BC and back up. And so if anyone can outdo me on social distancing and physical distancing, please have at it, but I did it with a PD catheter. So spring and summer also had a couple of new ups and downs. I got a text message out of the blue one day, with phase one coming, kind of winding down and not knowing what was happening with the living donor programs. There had already been a slowdown or even, much of a shutdown. You kind of gave up a bit. You just settled in that PD was going to be the way to go. I'd been through 32 workups, and so you were a little bit, I don't say frustrated, just down. It was a little bit tough. And then I got this message that from a friend who actually is another transplant patient, and that he'd been in contact with somebody who wanted to convert from being an anonymous donor to a directed donor. And I said, sure, yeah, whatever. Sounds good to me. Not thinking too much about it. I've seen a few of these kinds of messages in the past, and thought, okay. So anyways, we met briefly for coffee at Starbucks. She was very nice and incredibly motivated for a young lady. And but there's lots of hurdles to get through. You still have to do all your testing and your workups and all those kinds of things. And what was a little bit interesting about this one was our first call back. They said, no, it's a positive cross match. It can't proceed. And so, we both kind of licked our wounds and continued on, not knowing much. And 4 days later, a different coordinator texted me and said the opposite. Said, call me now, something else has come up. And we were a match after all. So that it was a very interesting August and September, work-wise, health-wise, personal-wise, and so we got a date. We didn't know. COVID was an interesting challenge for us there because we didn't know if we were going to be getting our date with wave 2 just underway. We were originally scheduled for the end of November or early November, and then we got a call back that there had been a cancellation. Could we do October 7th? Absolutely fantastic. We jumped in. I got my admission the night before. Anybody who knows me knows if there's a whiteboard, I have to find a way to vandalize it in some way. So I put my goals up. They had their goals for my nursing friends on the ward, and my goal was just to pee. Our surgery went forward. It was fantastic. October 7th, we had a challenge to each other on who was going to be able to walk to each other's room first, and she won. This is my living donor, Brenda, and one of my new best friends. She really has been a fantastic person to walk through this COVID journey with. She's been dealing with a lot of her own issues with trying to be a living donor, and I think she has no regrets whatsoever. And what do you do when you now have a kidney? Well, you get back to all the things you wanted to do. The little cup there, that was actually my post-transplant gift from Brenda. She has a little company that can produce custom-made mugs. So her and I have matching coffee mugs. I was skiing at week 10 after my transplant in Banff, and somewhere around week 12, I fessed up to my nephrologist, Dr. Cofield, that I had done that. I think she was, she had to pretend to be upset, but I think she was also a little bit proud at the same time. And I continued using my little trailer, and I even winter camped all through this last winter, Banff, Lake Louise, wherever I could find. So the other, big issue for us as transplant patients, as we've already heard from Marie-Chantal, and we'll hear in the next presentation from Maxwell, is what about these vaccinations? A big question for all of us patients. So based on the recommendation of my program, I got on the list for an mRNA shot. I got the Pfizer shot as soon as I was able to, and celebrated that very day. I went for a mountain bike in one of our provincial parks that afternoon. The only issue was a bit of a sore arm, and it was fantastic. I got my second shot, and following suit, I went for a hike at the Elk Island National Park, just outside of Edmonton here. So I am officially vaccinated, mostly. So how well do these vaccines work? I think that's the biggest challenge for a lot of us as patients right now. We don't know how effective they are, as Marie-Chantal already suggested. Some of the data that was coming out of Johns Hopkins at the time was talking about like 17% antibody, or 17% of patients having any kind of immune response on the first shot, and maybe as high as 50% after the second shot. But again, you don't know, and no one was offering antibody testing for us. So I think the biggest issue for all of us is we don't know what's inside of us. We don't know if we have antibodies. We don't know if we have T cells or B cells. So for the most part, we have to continue assuming we don't have immunity. So I can tell everybody I've had my 2 shots. I'm very proud of that, but I will be physical distancing, masking for the next little while as needed. And like I did with my transplant journey, I continue telling my vaccine journey through social media. I continue to encourage anybody to get the vaccine because I think, as we all recognize, it's going to take the community around us to be our protection. We need our family, our friends, and our coworkers to be part of our solution because we don't know where we are. And this is the last slide, Michelle. I see you coming up for my timing. The learnings for me were I lucked out in many ways because masks and distancing came in at exactly the time I was getting my transplant. So everyone around me was protecting me right when I was at the most immunosuppressed. Working from home and doing home-based peritoneal dialysis probably also indirectly helped keep me safe throughout this COVID pandemic. The vaccines to date are less effective. Number one, the relationships with our care teams are paramount in this. And we recognize that no one can navigate this pandemic alone, but especially those of us with complex immunities. And patient partners and our peers were a huge part of my sanity. Melanie Dieudet on the call knows that I've been part of a CDPRP patient study on mental health and the patient journey through COVID and the vaccines, and that's been a huge part of mine. And this thing is almost over. We don't know the exact date, but you can taste it. And that's all I have to say about that. Thanks, Michelle.
Thank you very much, Sean. It's a very inspiring testimony that you delivered this morning, and I'm sure all the participants appreciated it. Again, I invite you to put your question in the Q&A section that I will redirect at the end of the presentation. So last but not least, we have Maxwell Smith, who's a professor at School of Health Studies at Western University. Is a member also of the Ontario COVID-19 Vaccine Distribution Task Force. So another busy person that takes the time to be with us this morning. Thank you for that. And the title of the presentation is Vaccine Prioritization, excuse my accent, and organ transplant recipients. So you have 15 minutes. Thank you.
Thanks very much for that introduction, Michelle, and thanks to the conference organizers and especially Jennifer for the invitation to speak with you today. So as Michelle mentioned, I will be talking about vaccine prioritization, and Sean, thanks for teeing this up so well, and lovely to hear your fascinating journey over the past year and successful journey over the past year. Just as a bit of a disclosure, Michelle mentioned it, but I did want to make it clear that I'm a member of Ontario's Vaccine Distribution Task Force, as well as a member of the province's bioethics table. And these positions certainly inform my views, but the views that I express today don't reflect those bodies or the members within them. So what I hope to do in the next 15 minutes is really briefly describe the reasoning and justification for prioritizing organ transplant recipients for COVID-19 vaccination, provide a bit of a jurisdictional scan to illustrate how this played out across the country, and then end with highlighting one of the biggest ethical sticking points that I think exists around the prioritization of this population. So first, I'm going to just set the scene by talking about the ethics and setting priorities and really the role of ethics here. So this won't be news to anyone, but I think it's worth highlighting just the immense pressure to prioritize different groups for vaccination over the past 6 months or so. So we've seen very public calls for teachers and education workers to be prioritized, persons with disabilities, prison guards, others in corrections, homeless populations, shelter staff that staff homeless shelters, RCMP officers, police, fire, as well as even theater actors and NHL hockey players for some reason. Really a lot of pressure to prioritize a lot of these different groups. And I think it's really important to recognize and appreciate that, of course, there's good reasons to vaccinate all of these groups and good reasons even to have some degree of priority, at least for each of these groups, because, of course, we are all at risk from COVID-19, and certainly all of these groups mentioned here may be at increased risk of COVID-19. But what's evident is we need some way to adjudicate between the different priorities and different levels of risk, perhaps, that we see for COVID-19 amongst these different populations. And this is where ethics is really critical. Some would suggest that we just need to look to the evidence and that will tell us where to have those priorities. But it's really critical to appreciate that decisions about how priorities should be set reflect choices among competing values. Evidence alone can't tell us which choice is legitimate or justified. This is where the value judgment comes into play. And one such value judgment that must be made regards the objective or objectives that a vaccination program ought to have. And this is something that's often overlooked, that folks will look to the evidence of risk and say that that will rather straightforwardly tell us who ought to be prioritized for vaccination. But of course, we can have a lot of different objectives, and evidence would then point to perhaps different populations or different strategies for prioritization. So as you can see here, here's just a number of different objectives that have floated around. Preventing deaths, of course, has been first and foremost in many plans. Some have suggested the prevention of premature mortality by looking at years of life lost. We could also think about quality of life. We could think about preventing hospitalization and ICU admissions, going back to Simon's presentation and the importance of lifting that strain on our hospitals and ICUs. But we might also think about how can we deploy the harm-reducing powers of vaccines to reduce infections or reduce transmissions or even economic and social deprivation, because we know that that has been such a serious effect of this pandemic as well. And so there's really a lot of different ways we can think about how we might deploy the harm-reducing powers of these vaccines. And this will require a value judgment to say what is the objective or objectives that are most of value, most of worth. And I just note a paper in the bottom right here, which explored, this was actually published in 2020, but focused on influenza vaccination programs. And it really teased out all of the different ethical values that exist in vaccine prioritization plans. And it was very helpful to examine that. So I think it's also really critical to acknowledge what the evidence suggests COVID vaccines are actually capable of doing. And this is important because folks would suggest prioritizing some groups where actually there wasn't great evidence that the vaccine would have the best effects in that population in terms of achieving those objectives that were identified. And so you'll recall that in the last quarter of 2020 and into the first quarter of 2021, the evidence from clinical trials really suggested that the vaccines that were authorized in Canada were effective at preventing severe disease, hospitalization, and death, but we really didn't have a lot of evidence at that point around their effectiveness in preventing transmission and infection. But later on, as we had more studies and of course with more real-world data, we understood that vaccines were also effective at preventing transmission and infection, and we continued to see emerging data about that. And so based on all of this, at least for Ontario, which I can speak to best given my role in the task force in this province, we identified 3 program goals that were ranked in order and ought to be pursued in relation to an ethical framework that was developed. And really, we prioritized the prevention of death, that we wanted to deploy these vaccines such that they would prevent death as much as possible. Secondarily, to prevent illness, hospitalization, and ICU admissions. Third, to reduce transmission. And so the question was which populations or which strategy would work best to achieve these goals. And it's important, if you sort of link this back to the first point, that at least in December, January, February, it seemed very much that you would go to those, if you wanted to prevent death, go to those who are at the greatest risk of death and vaccinate those populations first. Now that we have more evidence around prevention of transmission and infection, you might adopt a slightly different strategy about how to do that. And so that leads me to the second part that I wanted to discuss, was the role of organ transplant recipients in all of this. So as we've heard from a few of the presentations already, organ transplant recipients, there's evidence that they're at a greater potential for a greater risk of exposure due to more frequent interaction with the healthcare system, greater risk of exposure to the virus, a potential for greater risk of infection due to immunosuppressive drugs, a potential for greater risk of transmission due to higher viral loads due to those immunosuppressive drugs, as well as a greater risk of severe outcomes due to immunosuppression or other comorbidities that might be underlying their health status. And so here's just one example of a paper where we saw that the fully adjusted hazard ratio for COVID-19 related death was 3.53 for organ transplant recipients versus 2.4 for those aged 60 to 69. So this is the kind of evidence that we would then use and map onto the objectives and underlying ethical values to determine the sorts of populations that ought to be prioritized for vaccination. So this is really where the reasoning and justification came from. And so I want to just note, at least because this will be familiar to most in Canada, the National Advisory Committee on Immunization, or NACI's, recommendations for vaccine prioritization. You'll see in stage 1, those 4 groups were all meant to be included at the same time. In stages 2 and 3, they were meant to be in rank order. So the idea would be you would vaccinate everyone in stage 1 and then walk through the groups in stage 2 and then the groups in stage 3. So you can see in stage 3, this is where folks under the age of 60 with underlying medical conditions, which would include organ transplant recipients, would or potentially be included and prioritized for vaccination. So you can see all of the different groups, everyone over the age of 60, as well as first responders and other frontline workers who would be prioritized on this recommendation before moving to at least those under 60 who would have an underlying health condition. And so this is how this actually played out across the country. And this is quite generalized. There's different details and granularity to this in each of the provinces. And even in Manitoba and Nova Scotia, we can see a little bit of distinctions here as well. But in most provinces, organ transplant recipients were prioritized for vaccination in and around March and April. And really they're situated alongside those that were 60 to 69 years of age, which really reflects the sort of similar or greater amount of risk that they had relative to those in that age population. And in Manitoba and Nova Scotia, at least initially, organ transplant recipients were not prioritized. And I'll return to that point in a second. I do want to return to this point that Sean had made about second doses. So we know that NACI also made the recommendation that second doses or the interval between doses could be extended up to 4 months. And this was an important area to really explore. And in Ontario, at least, we made an exception to an extended dose interval for organ transplant recipients for 2 reasons. First, because they are at greater risk, as I mentioned earlier, but also because we were seeing evidence of poor immune response from a single vaccine dose. And so a decision was made by our vaccine clinical advisory group of our provincial task force to prioritize those second doses at an earlier interval for organ transplant recipients. Okay, so back to the question of why not prioritize this population given the risks that we've seen and underlying values that I've identified. So clearly this received a lot of news. We saw this in Manitoba, a lot of attention to the fact that they were sort of deviating from what other provinces were doing. And of course, many with underlying health conditions, including those who had received organs, were calling upon governments to include them in these prioritization plans. And many suggested that the reason that these groups weren't being prioritized is because doing so might slow down the race for herd immunity, that really getting into the granularity of specific underlying health conditions rather than having a kind of overarching broad strategy could slow things down. And so that really leads into this last point that I want to raise in the presentation, is this tension between speed and equity in the rollout of vaccines. So this really, I think, became center stage in the first quarter of 2021, where people realized that we need to be as quick as possible, of course, at administering vaccines, and that some degree of precision, which really equates to some commitment to equity, may need to be sacrificed in order to be as quick as we want to be. And undergirding a lot of these arguments, and this, I can tell you, there was immense pressure on myself and others that were involved in thinking about this to really make a straightforward, simple plan for vaccine prioritization, some suggesting to just use age. That would be the sort of most rapid or expedient way to administer these vaccines. So the arguments here are that age is the best proxy for COVID-19 related mortality and hospitalization. We know that the vast majority of deaths and majority of hospitalizations have occurred in individuals over the age of 60. So that's a good reason to perhaps use that as a good enough proxy. Many argue that it would simply be faster. It would be less confusing for the public, which would otherwise jeopardize success of the program. It's easier to verify, of course. There was this sort of erroneous view that other jurisdictions just used age, despite the fact that this didn't really appear to be true. But nevertheless, some suggested that limited exceptions could be made. So we can include healthcare workers in prioritization schemes, and maybe a couple other different groups like dialysis patients or homeless populations. And so I just want to end by really articulating, I think, 2 reasons why this approach or proposal was rejected. So one was a reason based in equity. And the argument really is that if there are no principled or evidence-based reasons to differentially prioritize populations in relation to the metric of interest, such as the risk of death, then doing so will be arbitrary. And arbitrariness is inequitable and unfair to those populations with equal moral claims who end up excluded or deprioritized. And really, in the back of my mind, if we knew that someone who had received an organ who was in their 30s was at a similar risk of mortality to a 65-year-old, it seemed quite inequitable to simply use age and wait until we get to the 30-year-olds to get to those populations who really are at great risk of mortality. But there's also non-equity-based reasons that I think are important to highlight here for prioritizing organ transplant recipients as well. So I think arguably, and this depends on supply, vaccinating populations at greater risk of mortality earlier could more effectively and rapidly prevent undesirable outcomes like mortality and morbidity. Prioritization as well may simply mean that we could start vaccinations earlier, but not necessarily wait to vaccinate others until those priority groups are vaccinated. So even if we aren't waiting for all organ transplant recipients to be vaccinated before moving on to other groups, we can facilitate that population vaccination coverage quicker if we get to start with those populations at least a little earlier. And I don't think that including these populations needs to complicate the overall rollout. It can be delivered in clinical modalities that are separate from a lot of the different ways that vaccines are being rolled out. And then finally, I think that including these populations in priority schemes preserves the expressive function of prioritization. If we don't suggest that these populations are a priority group, this might communicate to those groups that they aren't in fact at greater risk, and there might not be as high of an imperative for them to become vaccinated. So I think there are other non-equity-based reasons as well for including these populations. So I'll stop there. Thanks very much for your attention, and I look forward to a discussion.
Thank you very much, Maxwell, for this this conversation and this presentation. We will now move to the question period. So please do write your question in the Q&A in French, Q&A feature. And I already see one or two questions, so it gives you the time to write yours. So Simon and Marie-Chantal, you described adjustments to standard of care that had to be made during pandemic waves. Was there any silver lining in the form of discovering of efficiencies that we can take forward beyond the pandemic? So you can, Simon or Marie-Chantal, who would like to go first? Are you there? I can't hear you.
Sorry, it's hard because we can't make eye contact to look at who's going to go first.
I know. I didn't see. I see Marie-Chantal now. So,
but Simon, go ahead.
Go ahead.
So, you know what? It was very interesting because we had to change the way we did a lot of things all across the hospital. And there are actually some silver linings about patient care in general. I mean, we've actually spent a fair bit of time figuring out what elements of care were truly required versus which ones were just sort of a long-standing habit. So, for instance, ordering blood work routinely. You know, we reduced the amount of blood work that we were drawing, and this probably is going to result in actually more efficiencies across the system as we need to transfuse fewer patients. We also standardized a lot of our processes for ICU admission and transfer, as well as procedures, so things like intubation, bronchoscopy, et cetera, because we were doing everything sort of under very resource-constrained circumstances. We really pared back to the bare bones. The question that I think is still a bit unknown is how many of these sorts of efficiencies are going to actually remain, because we're currently, you know, ramping down our ICUs and closing our COVID unit just last week. How many of these sorts of changes in practice are going to remain as we move forward with regard to critical care? You know, it's still a question, and maybe we will revert back to our old ways of doing things, or maybe we will retain this very efficient practice that we have right now. But I don't know what's going to stay.
Marie-Chantal, thank you, Simon.
From my perspective, I think one of the great addition of the pandemics in our patient care is telemedicine, telehealth. I think it was greatly appreciated from our patient because before the pandemics, we were not using this. But again, some of our patients during the first wave didn't want to come to the hospital. Some of them didn't want to have their blood tests. So I think we have to remind our patients that there are some issues that could be addressed by telemedicine, but not all. And we need to meet them. We need to have blood tests. But I think it's good to integrate this part for the follow-up of our patient, which is really more convenient because they don't have to come. Some of our patients are living remotely from our center. They don't have to pay parkings. It's really convenient. So I think this is one thing that I hope will stay and will work to improve all the telemedicine. But yeah, so I think it's one of the legacy, one of the positive aspects of the pandemics on our patient care.
Okay, that's good to know there are some positive aspects of this whole pandemic, and I'm sure there are more than we could think of from day to day, given the difficulties that we have to endeavor. I have another question for Marie-Chantal. If we choose easier or safer patient for transplant during pandemic waves, is there an obligation to prioritize the trickier patients during the lulls, during the between two waves, or would this kind of equity over time be ethically required?
This is a very good question, and we had this. We ask ourselves the questions, but since we prioritize, if I could say easy patients, I don't like the word, but but easy patients for a very short time frame, just for 1 or 2 weeks to just readjust and be sure that the system was ready to take care for these patients. And after that, we open to all our patients. So I'm not sure that, there were so much penalized. And again, we always continue to do highly sensitized patients because we believe that the benefits, if these patients could find a compatible kidney, although we are in any waves of the pandemics, it is probably their only chance to have a compatible kidney. So we continue to consider them in our patient, no matter what we were in the pandemics. But of course, if it would have, we would have prioritized for a long time easy patients. I think that's something that we would need to ask. But since it was for a very short time frame, I think it could be, it didn't penalize so much. Patient.
Okay, thank you very much, Marie-Chantal. Simon, are there any lessons learned during the pandemic in terms of processes efficiency? And if so, will they be applied to modify processes after the pandemic?
Yeah, so I actually just added there, I think one of the big changes in terms of process efficiency for critical care resources is really this concept of load sharing between centers. Previously, we would have like one hospital in the black, meaning like completely overwhelmed, less than an hour's drive away from hospitals that have tons of resources, and we'd be canceling surgeries and holding up ORs, including potentially donation and transplant related activities. And I think now there's this much more of a concept of like a unified province-wide approach. It's not about just our single center. It's about, how can we share the load of patient need equitably between centers. And if this means transferring a patient to a nearby hospital to make room to continue up with ORs, I think that will be beneficial to many patients. And hopefully that carries on to some extent going forward.
Yes, thank you, Simon. For Maxwell now, for Max, the trade-off between values in allocation was fascinating. As efforts are made to be more precise in allocation, it gets more and more complicated. Did this complexity contribute to the challenges in rollout in Ontario? At least from the public perspective, relying on vaccine hunters, Twitter, and hunting around for a slot out online, did this paradoxically have equity reduce effect to your opinion?
Yeah, thanks for the astute observation and question. I think the idea that it gets, the more precise we get, the more complex and confusing it might be is a great one. And that's one we heard from those that were on the ground and were a little bit more reluctant, I think, to include underlying health conditions as a priority population group, whatever they might be. So I think, part of the way that some dealt with that was to simply say, public facing documents would say the priority groups are age-based or broad sort of essential worker-based, and wouldn't publicize that, yes, there's other underlying health conditions, but we would be vaccinating them in clinics or in the different services they might attend. And I think the sort of unfortunate consequence of that was that some folks may not have seen that they were actually prioritized, or may not have known that, or there was a general perception that they weren't being prioritized when in fact they were. So I think, the way that we needed to really address that was to be very transparent about how this is working. And, the fact that transplant recipients are prioritized need not, be complex for the general member of the public who might just be going to a mass vaccination clinic, but it's still very important that that's articulated in the reasons for it. So I think it's a great question.
Thank you, Max. You have in the Q&A, you have congratulations for your great presentation as well, that is mentioned. And Linda Powell is making a comment to the following: a good conversation as well if a booster third shot is required in the near term. And if I can, we still have a bit of time because there's a long break between 11. You may fear that I won't have time to read your question to the speakers, but you still have a little bit of time if you desire so. So Simon, you have another question. You mentioned stimulated triage exercises in your hospital in preparation for possibly having to put in into operation. What were the psychological impacts on healthcare professionals of those exercises, and what sort of processes were put in place to help people through this?
Yeah, that's a great question. So, the triage exercises we did had sort of a few purposes. So one was just to test whether or not the policies that we put in place would actually function. How would it work? Who would call who? But part of it was also about, stress testing clinicians and sort of getting this concept of triage socialized. As clinicians, you always want to help the patient in front of you, and it's completely antithetical to our normal way of operating to sort of put aside your responsibility to the patient directly there and say, I cannot provide you with the resource I would, I have to provide it somewhere else. And this is stressful for clinicians who are, not just intensive care physicians, but also surgeons, for instance, right? Because critical care resources are shared across all programs. So if you have a team that cares for organ donation and transplant, and you're going to say, you know what, we're going to stop our organ donation activities at this hospital or transplant activities at this hospital, just getting people into the mindset of being like, I'm going to have to let some of my patients go that I otherwise would be able to help. It was really challenging. And the simulations were helpful to get people to understand that, like, this is what it's going to look like. This is what it's going to feel like. And doing this in advance of actually the day, that horrible day, if it ever came up, was very helpful to get people in that mindset. What we did in terms of supporting people is we had, as part of the simulation, was we said, okay, who do we need to support, right? So from a clinician point of view, who can we get there? So we had ICU supporting the bedside physicians, ER, internal medicine or surgery. from a clinical point of view, but we said, what's the role of social work? What's the role of spiritual care? What kind of communication supports can we provide when people have to deliver this very difficult news to patients and families that, we cannot provide you the care we would like to do? And so we developed communication tools, both written and sort of verbal scripting to assist clinicians with these conversations that they never had before. So it was really important to do the simulation work. And I think it was a very positive experience, even though it was sort of terrifying for most.
Yeah, I can imagine that. To all the panelists, if I may ask a more general question, in terms of pandemic preparedness, post-COVID, I suppose, I presume that, it's going to be very important to reflect on, what we have done right and what we have done maybe less right. To be ready for another pandemic. I mean, what lesson have we learned from this pandemic? And one sub question that I would add would be, the fact that we would dedicate some establishment to COVID, to the treatment of COVID, given the fact that we're able to organize, in case of emergency, all the, different possibility for doctors to be able to work in different setting. Would it be a good option to improve, capacity, instead of, you were mentioning, the fact that the emergency unit ICU unit were completely in full capacity at certain points. So if we dedicate some, establishment to deal with COVID or not deal with COVID, do you think that would improve? Or more generally, what lesson have we learned from this, preparedness or unpreparedness to this pandemic? And maybe if I may add, I mean, for Sean, from the patient partner perspective, how would you, frame it differently for hopefully not, but if we would have to face a future pandemic?
I think one of the things I observed right off the bat, especially in wave one, probably more than wave two, was just how many of the living donor coordinators and particularly deceased donor coordinators were the most easy ones to poach to use for ICU backfill, because many of them had critical care backgrounds. So I think if we were to, evaluate what just happened and what is still finalizing now, I think it would be, how do you address the fact that there is going to be that crossover? You need those critical care or emergency nursing skills if you have a future pandemic, but how do you maintain both so that you're not shutting down your living donor program completely? I think wave one, as Marie-Chantal pointed out, was a very different response because there was almost everything closed very, very quickly. And wave two and wave three, they found ways through. They kept the highly sensitized program going, but through wave two and wave three, more and more programs kept their paired exchanges continuing. They found ways to get ORs and things like that. But I think that sharing of staff was not just ICU to ICU, it was also former ICU staff and former ER staff that were, essential to keeping those ICUs going.
Thank you, Sean.
Michelle, perhaps I'll offer two things that I think that we shouldn't do, two things we really need to avoid. So I fear that given the immense amount of investment that we had to make into our healthcare system and public health system over the course of the past 15 months and the state of our economy, that we may see decision makers follow up in the next several months or years with austerity and a lack of investment and continued investment in public health. And so this speaks to your question about capacity. I think this is the time to renew our investments in these areas. And I think there might be a real it's not going to be seen as attractive doing that, I don't think, politically, perhaps. And the second thing, I think, this is to Simon's great work with critical care triage. I mean, I worked on some of that at the provincial level as well. I know that a lot of people had to think about that during the pandemic, and now that they don't have to, they do not want to return to thinking about that. Where's the appetite to continue simulations and thinking hard about these really challenging problems? It's going to be attractive to put this behind us. And I think we really need to push forward and make sure that we learn those lessons and continue this great work to make sure that we're prepared going into the future. Thank you.
Yes, thank you very much. Simon, do you want to add something?
Yeah, I'd sort of say from, I think one of the big lessons learned, going through the waves is we realized that, what your limiting resource is going to vary, and you need an approach that's adaptive to the changing resources available. Like in wave one, it was PPE. I remember our hospital, they're like, okay, guys, we have 4 days of PPE left. None of us knew if we were gonna are we all gonna die of COVID? What's gonna happen? And then later it became ventilators. And then towards the end, it actually ended up becoming staff, like the respiratory therapists and the nurses. As we'd streamlined our care processes, it's like, who's going to care for these patients? So I think, there needs to be more work done in terms of creating a system that's adaptable to allocate resources and doing this in advance so that we have something flexible and fair and can allow us to preserve those really important aspects of care beyond just COVID-19, so we don't get blinkered into, this pandemic or the next pandemic. There's all of this other stuff going on in healthcare we need to maintain at the same time. And if we don't do it in advance, we're going to just focus on the one major illness that's in front of us from the pandemic and ignore other things like donation, transplant, mental health, et cetera.
Yeah, etc. And all the delays and stuff. Yeah, Marie-Chantal, you want to add something? And then I have another question from Presento and another comment in the Q&A.
I just want to add that I think, I speak from my province point of view, but there was a lot of hype, of anxiety about the triage protocol in the ICU. And of course, I think it was something very difficult for healthcare professionals, but we had to remind ourselves that we were doing triage with COVID. We stopped elective OR. We decide that we would prioritize patients with COVID in our healthcare system, but we will stop to do screening exam. We'll stop. So it means that people with cancer won't be screened or won't have their surgery and they will die. So there was already triage protocol in our system, not only at the ICU levels, but when we stop all our kidney transplantation programs, it means that some people will die because of that also. So I think we need to have a more global view of all the triage and prioritization in our system.
Yes, thank you, Marie-Chantal. Sean, did you want to add something? I see a comment. That's okay. So, yeah. Prosento, do you want to, I saw you had a hand raised. Do you want to go ahead? In the meantime, if you do, just raise your hand again. And in the meantime, I see a comment from Carapeni in the Q&A. Has anything around debriefing been completed for these teams? Understandably, all teams have undergone a great amount of duress in preparation for the described scenarios and a great amount of stress throughout the pandemic in caring for these PTS, etc. How is this being addressed? So I don't know who wants to address this question. Marie-Chantal?
I'm not sure about the debriefing of teams. I think probably Simon, who was in the ICU, probably better to answer because your transplant teams stay with, it was a cold zone, so they were not exposed to COVID patients, so I'm not sure that I'm the best person.
All right, Simon or Maxwell, if you want. Simon?
Yeah, I was going to say Maxwell actually had a great point. I mean, I think for a lot of people, I just finished a week in the ICU right now, and I think Maxwell's point that this is important work. There's fallout and ramifications of what's been happening, and those at the front line, a lot of people just don't want to touch this with a 10-foot pole right now. Is like, I think that's where, at least talking to the nurses and stuff in the unit this week, most people are like, let's just get on with our lives and have a summer and get vaccinated. And I don't, for some people that might be the right way to address this, but I think there needs to be a lot of work done, because every team experienced this differently. Every individual experienced this differently. Like, hospitals have gone and hospital workers have gone through a collective trauma, and we're all going to respond differently. So I'm not sure what the best approach is, but I know that for many people right now, it's just like, let's move on with our lives for the time being and enjoy some sunshine. I don't know, Max, if you have any other thoughts on that, but
yeah,
good.
I think the other thing, which might be even a little bit more worrisome, is there's this new phenomena termed the Great Resignation, right? That we're seeing a lot of people using this as an opportunity to resign or retire from their positions at this point, and you lose a lot of institutional memory in doing so. And so I think it's incumbent upon us to, we obviously there's a lot of moral distress and really just distress about this whole experience, but ensuring we can still cultivate those lessons while they're fresh in our minds will be really critically important.